morning. I'm Dr. Larian from Center for Advanced Parathyroid Surgery, and we are doing a live question and answer session. So, any questions you have that you may have already sent in, I'm going to go through, and any new ones are welcome. I always find that these sessions challenge me because they stretch me to the limits of what I understand, because you guys have phenomenal questions and also make me think, which really helps me. So I have to thank you for forcing me to be better. In any case, let's start. We have a large number of questions. The first question is coming from Marble Picker. Hello, Dr. Larian. Thank you for doing these question and answer sessions. My pleasure, Marble. I recently watched your video about persistent versus recurrent hyperparathyroidism. I'd be interested in your opinion on which of these I had. My first parathyroid surgery was January of 2023, one adeno removed with a four gland exploration and IOPTH. PTH dropped more than 50%. Okay, good. 2023, 4 gland, one removed. Okay, I'm just taking notes. Let's see. Post-op February of 2023, calcium was 2.53, which is upper limit of normal. PTH was 55, which is also upper limit of normal. Okay. Vitamin D was 58, which is good. May of 2023, so now it's 4 or 5 months later. Calcium is high. June 2023, calcium is back into the normal range with PTH that's good in the normal range and vitamin D that's normal. January, so now a year later, calcium is upper limit of normal. PTH is upper limit of normal. Vitamin D is very good. November, calcium is high. PTH is high again. My second parathyroid surgery was in June of 2025. So based on the fact that you had numbers that looked like they were trending upwards, right? They came down a little bit, then more down, and then it started trickling back up. So by May, your calcium was higher. By June, your calcium and PTH were pretty normal, but January, which is exactly a year later, your calcium and PTH numbers were, I think you had persistent. Because we're mincing words here, January, your numbers were, both of them were in the normal range, but both were calcium high normal and PTH high normal, right? Instead of having this relationship. And so because of that, you were, I think you were on your way of inching back up. So by November you were here, and by January you were outside the normal range, and it was clear by January the numbers were abnormal, but they don't become abnormal overnight. So they were in the process. So it was happening within the first year. So I would call yours persistent. All right. Okay, so my second surgery was June of 2025, one targeted gland removed with IOPTH dropping more than 50%. I'm waiting histology to confirm microadenoma. I think it was recurrence. My symptoms improved, although they never completely resolved. I'm in the UK and I had PET colon scan to locate the very small target for the second surgery. Thank you. Very good point. Let me see. Let's see if I bring the. So, in my hands, in my experience, the reasons for failure of a surgery, right, which means the disease persists. Recurrence to me means more than a year later, 2 years later, 5 years later, you have hyperparathyroidism again. And that can happen anywhere between 3 to 10% of people who have a successful first surgery. They're done. In their lifetime, they can get another parathyroid. That's a recurrence, okay? The disease was completely cured and gone, and then another one came back. But yours came back at 1 year, it was back, right? So exactly, you had surgery in January of 2023, January of 2024, your numbers were both high normals, right? And by November of 2024, your numbers were clearly abnormal, okay? So I think you had persistence, right? And probably what you have had, we don't have the final pathology to see, but probably what you had was one larger adenoma, right, which was producing a lot of PTH, and a smaller one here, right, that was microscopic, perhaps just a few cells, right? And so it really wasn't producing much PTH. So when you took this one out, the PTH dropped into the normal range because this one really wasn't producing much extra, being a few cells. And so over time, this had a chance to grow, right? And the rate of growth was probably slow enough where in the first year, the numbers weren't big and problematic. So I think that's why it took so long to show itself. But I think you had persistence because of the way your numbers look by January a year after. Okay, I'm glad you had surgery again. This is the reason why I'm not a big fan of a 4-gland exploration, because if you have a 4-gland exploration and you have this scenario, you don't see it, right? You're not going to see a parathyroid that's I'm just magnifying. If you have a parathyroid that is that big and you have a tumor inside of it that's this small, it's not going to be visible by looking at it. It's not going to be visible by putting radioisotopes in it and putting a Geiger counter, like a minimally invasive radio guided parathyroidectomy. Is not going to pick something microscopic like that up. It just doesn't have enough power to. It's not producing enough PTH for the PTH testing to pick it up. There's just no mechanism to see this scenario and be successful in removing it. It's just impossible at this point. Hopefully in the future we have better ways of dealing with it, right? But at this point in time, this is impossible, and that's what I see that it looks like you had. And I'm hoping that's what you had, right? That you had 2 adenomas, one significantly larger than the other one, and therefore this one needed time to grow to show itself, and 2 years later, this went from here to this size, or hopefully even larger, to be picked up on the PET choline. And that really shows you the value of PET choline. So the reason I don't like doing a 4-gland exploration if I don't clearly have the number and the PTH goes down is that these other glands have a blood vessel going in and a blood vessel coming out, right? And in the process of doing surgery, let's say you go in, you remove this one, your PTH comes down, right? You go in there and you look for this one, and you find all 3 of them. You're like, oh, good, they all look pretty normal. And in the process of doing that, you, by accident, damage this blood vessel and that blood vessel, right? But not this one. This one is intact, right? These 2 parathyroids die because the blood vessel was cut. And the normal parathyroids, when you have hyperparathyroidism, so if you have hyperparathyroidism and you have one abnormal with a tumor in it here, one normal one without a tumor in it, right? And both are producing very little at the time when this is small, right? And in time they grow. But as this tumor grows and is producing more and more hormone, the normal parathyroid that's not working shrinks and gets smaller. And the blood vessel going into it that was relatively big and coming out was relatively big shrinks right along with a smaller parathyroid. So it's easier to cut one of the blood vessels of a smaller parathyroid because it's smaller, it's more delicate. In any case, so if this happens where these two parathyroids die and 2 years later you come back, you do a PET choline scan, it shows you this one, and you go in there and do surgery and remove it, right? So now you've removed this one, and lo and behold, you check your PTH, and if your PTH started at from 100, right? Or let's say, in your case, let's say it was 65. Right? And you check it after you've taken this one out, your PTH is going to go to 5 at 5 minutes, 2 at 10 minutes, and 0 at 15 minutes, because now you have no parathyroid. And that's why a four-gland exploration is something that should be reserved for people who don't have a drop in their PTH, because the PTH drop tells you that the other glands are not overproducing. So there's no point in looking at them because you're not going to identify an abnormal gland that has a tiny microscopic piece of parathyroid. If it doesn't drop enough, so let's say you start at a PTH of 100, okay, and you take this one out, and the PTH goes exactly by 50%. So at 5 minutes, it's 65. At 10 minutes, it's 52. And at 15 minutes is 49, right? To me, even though that's a 50% drop, that's not an adequate drop. In my experience, when I've settled for this, those patients have shown a persistent disease or a parathyroid that was abnormal, or calcium and PTH numbers that showed abnormality within a year, right? So I generally try to go for more of a reduction, right? So the experience of your surgeon, that's where it matters, right? You look at these numbers and you judge, is this an adequate drop or not? If it's not, I'm going to go look for the other glands. Anyways, so that's why I think you had a long-winded way of saying I think you had persistent hyperparathyroidism. Very good question, and thank you for sharing. Nina Bonesk, question for your Q&A. Can you speak about the use of choline PET scan and if it might become the new standard of care? It seems like it's only available at university medical departments. Sure. Let me go through and get to imaging studies. So there are currently 4 imaging studies that are commonly accepted and are being done, right? In the US, the PET choline scans are available, as far as I know, the last time I checked, in 6 centers in America, and in the UK it's more widely available and it's more approved. In the US, it's still getting to be more commonly used. The problem with the choline, the 18-fluorocholine isotope, is that it's a very unstable isotope, so it degrades very quickly. So the imaging center has to or the hospital has to get it and use it pretty quickly, otherwise it just fades away, it just degrades, right? So you have to have it organized very well, bring the material in, have the scan set up so that you use all the material, because by some short period of time it degrades and it's useless. So it's not like something you can bring in and keep it for weeks and whoever can come and do the scan, we have the isotope ready. It doesn't work like that. That's the inherent problem with the PET choline. That's what's going to make PET choline be a limited scan ultimately, right? And not the ideal type of scan, because it's just you have stability issues, right? So in my mind, ultrasound is the gold standard, right? in a majority of cases, when I do an ultrasound in the office, I'm able to find the parathyroids. And my patients don't then need to have system EBs, PET, I'm sorry, 4D CT scan or a PET scan or choline PET scan. None of them. The ultrasound, I would say roughly about 75% of the time, does the job. I do the ultrasound, I see it clearly in the office, I compare the size of the parathyroid to their PTH number. If it's correlates, because in the old world of hyperparathyroidism, calcium doesn't correlate to the size of the tumor, PTH does, because the parathyroid gland is only producing PTH. It's not producing calcium. So the PTH number reflects how big. So if your PTH is 250, you got a fairly sizable parathyroid. It should be visible on pretty much any scan, right? Unless it's in the chest, so the ultrasound won't show it. And there is the limitation of ultrasound. It doesn't show parathyroid that's in the chest. So your chest bone is here and your collarbones are here. So if your parathyroid happens to be hiding down there, ultrasound can't see it. Ultrasound also doesn't see, these are locations of parathyroids. Ultrasound also doesn't see when the parathyroid hides behind the breathing tube. This is the breathing tube and the voice box. If your parathyroid is tucked in underneath that, which can happen rarely, then the ultrasound won't see through the cartilages of your breathing tube or your voice box either, right? So those are the limitations of ultrasound. But it is a very good scan, and I would say in the hands of the surgeons, it's an even better scan, because the advantage we have as surgeons over radiologists is that we can do an ultrasound, and then when we do surgery, we see what's there in the person's neck. So we have a way of testing our findings on ultrasound to the findings in the operating room, in the anatomy. Radiologists don't have that opportunity. They have a lot of experience. They're brilliant. The radiologist I work with, Dr. Gordon, is brilliant, right? But she has a limitation. She's not going to be able to see what's going on. And so I do the ultrasounds first. And if I don't see it on my ultrasound, then I usually order a 4D parathyroid CT scan, right? And the good thing is that I have a conversation with my radiologist. I let him to limit the dose of CT scanning, so I give a lower dose of radiation, right? And I find this to be much more reliable than the System EV SPECT scan. System EV SPECT is less reliable when the PTH is less than 150, which means when the tumor is smaller, this is a less reliable scan. Now, the reliability of the scan improves if you have a place that does it all the time. The reliability improves if between the time of the injection of the System EV percentage 8 material and the time they do the scan, it should be within 5 minutes. It shouldn't be 10 or 15 or 20 minutes after the injection, because the effect is gone, right? And that's hard to organize for some busy places, right? To get things organized to the point where it's inject, scan, right? Because the injection can be done in another room, and there's staff needs to bring you over, and all sorts of functionality problems. So this is a problem. If I order the scan, I call the radiologist and make sure they do it within 5 minutes, right? I rarely order the scan. And PET choline, I don't think it will become the standard, because it still has radiation involved where ultrasound doesn't, right? It should be a backup scan if you are at a place, if you're working at a university hospital, or your doctor is at a university hospital and has easy access and they can organize it for you. That could be a secondary scan over a 4D scan, right? I can see value in that scenario. I have to say that because of the limited experience we have in the US, because of limited availability, I still don't have enough experience with the PET choline scans to know how good they are in primary cases. I've only really used them in revision cases where they've had a failed surgery somewhere else. They come to me, I do ultrasound, 4D scan, possibly even sestamibi. You usually come in with a sestamibi themselves. And they're all negative. Then I enroll them in the research study at one of the bigger university hospitals and for them to get this PET choline scan done, right? That's been, so the numbers have been limited in the US for us to be able to comment as to how reliable and good they are as a primary study. But it still has radiation. So I would say ultrasound is my first choice because there's absolutely no radiation. And not only that, but also on ultrasound you can see the parathyroid pretty much exactly. You can see the blood vessel coming in to feed it, right? Here's the blood vessel feeding this particular parathyroid. You can see same size, and this one same shape and size. And then in addition, not only do you see a parathyroid on this ultrasound, but you also see a thyroid nodule. And if you need to address a thyroid nodule at the same time, you can go in there during surgery and make an incision in the thyroid, take out this nodule, and not compromise any of the normal thyroid function. So you can do a lot with an ultrasound that even a PET choline isn't going to offer you. So I wouldn't use it as a primary study. I would use it as secondary. Again, a very good question. Eogan Murphy, thank you for taking the time to consider these questions. My pleasures. Apologies in advance for the units I state below being different to the US. I'm in Ireland. Lab ranges are attached. Thank you very much for attaching it. Eogan, I hope I'm saying your name right. I apologize if I'm not. For 5 years, I've had consistently very high PTH levels, latest 134. At the same time, my calcium has been consistently normal, latest 2.4. So in the middle of normal range. My endo thought it was as a result of my low vitamin D level, as it was undetectably low 2 years ago, less than 15. That could very well be, right? So let me go to the chart of what causes So, secondary causes of elevated PTH. So, low vitamin D, yes, that's a possibility. That could certainly do it. I've been on vitamin D supplements ever since, and I'm in the normal range for the last year. So, if this was the issue and you take the supplements, then everything would have been cleared up. So, I'm assuming that's not the problem. However, since supplementation, my PTH has not dropped, nor has my calcium changed. My endo says that I just have overactive parathyroid glands and to keep an eye on things. No. No, you need to figure that. You need to go through this chart. Am I not likely to have normal calcium? You are very likely to have normal calcium hyperparathyroidism because you've corrected this. But you also need to look at other potentials. You need to look at your calcium intake by checking your 24-hour urine calcium, right? If your blood calcium level is low, which is in fact the case, you need to check your 24-hour urine calcium. If that's low, then that means your body's not absorbing the calcium you're consuming, or you're not consuming enough, or you may have malabsorption causing it, right? You have to check your magnesium levels, and you have to make sure you're not on any of these medications because they can also cause elevations in your PTH. And obviously you need to look at kidney function to make sure your kidney function is normal. Okay? I suffer terribly with hyperparathyroidism symptoms. I'm 49 years old and feel like I'm 99. Well, let me look at your numbers. You've given me the chart. Yeah, so yeah, your numbers are high. Okay. All right. All right. You again. I would I would get a 24-hour urine calcium, right? I would make sure you're not taking any of these medications, right? If you are, and it's possible for you to come off of it, I would come off the medication and check your labs a few months later to see if the PTH comes down. If it doesn't, then it's not related to the medication. I would do a blood test to check for celiac disease or true gluten intolerance, which is an autoimmune disease which causes malabsorption. I would check magnesium. I would check the 24-hour urine calcium, which will tell you if you have either renal calcium leak or you're not taking or absorbing enough calcium. I would check kidney function, right? Which is a simple blood test, right? So through a blood test and a 24-hour urine test, you can figure all of this out, right? Once you've excluded these possibilities, right, then you're left with normal calcemic hyperparathyroidism, right? I'm sorry, yeah, normal calcemic hyperparathyroidism. Now, in the UK system, you are going to face massive issues because the NICE guidelines, which is the guidelines the UK has set up for treatment of diseases in the UK, including hyperparathyroidism, has no mention, intentionally has no mention of normal calcemic hyperparathyroidism, right? They treat normal hormonal, right, when you have elevated calcium, but they, in their guideline protocols, they have no protocol for treating normal calcemic hyperparathyroidism. And you're going to have an uphill battle fighting the doctors over there, right? And I would approach it by doing this. Download this. Download this 2-page summary, right? In it, make sure you talk your doctor into doing a bone density study. If your bone density is low, then if you have osteoporosis, then push, right? Also in here, mark off how many symptoms you have, right? And then show them normal parathyroid function, right? And normal calcemic, okay? And then you have data that you're putting in, just like you've done. And then go here and say, the workup of normal calcemic includes all these possibilities that needs to be explored. I want to do the blood tests and do all these things. I want a bone density study. If that's negative, I would do a CT to see if there's any kidney. So you're trying to convince a system that doesn't want to treat you, basically. And it's going to be very hard, okay? But if you have symptoms, I would push, and not relent, okay? You will, I mean, I know it's hard to find doctors that'll do it. I know Dr. Khan at Oxford does do surgery on a wider range of presentations of hyperparathyroidism, and you may need to seek his help over there, okay? Best of luck, my dear. This is a tough situation, but don't relent, right? Do the labs, figure it out. Hopefully you have something that medically can be treated, magnesium deficiency or low calcium intake or something like that, so you don't need to resort to going to fight for getting treatment. But if those don't pan out, then for sure push. Don't relent. It's your life and you're very young. Good luck. Katrina Brown. My mom and I both had parathyroid adenomas removed last year. I had my daughter's calcium PTH vitamin D checked, and I'm confused at the results. May 30th, 2024, at age 7, fasting morning, calcium 10, PTH 22. Okay, that's not a bad. Vitamin D is 29 on the lower side of normal. I started her on low-dose vitamin D supplements at the time. Her labs were just checked and are July of this year, so a year and a few months. At non-fasting afternoon draw, calcium is 9.3, PTH is 61, vitamin D is 36. Her vitamin D is improved, yet her calcium is a bit lower, and PTH is 3 folds higher. That's not a problem. Very good question, Katrina, but let me explain. Parathyroids work on on a curve when you look at the parathyroid system, right? So again, there's multiple things we need to look at. First, parathyroid glands, these four, are constantly looking at the level of calcium in your blood. As the blood is coursing through these glands, they look at the level, and if the calcium is low, they produce PTH, which goes to your bones and release calcium, goes to your kidneys, tells your kidneys reabsorb calcium back, activates this enzyme that changes inactive vitamin D to the active vitamin D, and this helps you absorb more calcium from your bloodstream, increases the absorption from 20% to 80%, right? 80%. And there's all these feedback loops that exist here. Everything promotes or suppresses the loop itself, right? Now, on this, the way this happens is that on the surface of the parathyroid glands, there's these calcium sensors, and there's a multitude of them, hundreds of them probably on the surface, right? And when enough calcium is attached to the surface, release of PTH stops, right? And when there's not enough calcium, the cell releases PTH into the bloodstream so that the process happens, right? All right. So the relationship between calcium and PTH follows a curve, right? And if in this scenario, for this person who is perfectly normal, right, their set point for calcium is 9.5. So if their calcium, this person's calcium goes to 10, their PTH is going to be low, right? And if their calcium goes from 9.5 to 9.3, their PTH is going to be very high, much higher than that, right? And this is perfectly normal because this person is moving on the curve, up and down on the curve, right? So to me, these numbers really look like, fortunately, at this point in time, your daughter's parathyroid system is working perfectly normally. All right, so that's the good news. Continue giving her vitamin D. My children take vitamin D. There's chronic low levels of vitamin D in Western environments, Western world, probably the rest of the world as well. Who knows what the reason is exactly? I'm sure it has to do with all the garbage we put in our food system, right, or farming and so on. But you're doing the right thing checking her. You know, since your mom and yourself have had it, you have a higher degree of suspicions, and you have to let her know that she also, with her annual exam every year, should check her calcium, PTH, and vitamin Ds for the rest of her life, because she'll detect this disease setting on way before her doctors will. And it's a very good idea that she does it, okay? But at this point in time, based on the numbers you're showing me, I don't think she has hyperparathyroidism, fortunately. Good luck, my dear. Good question. Good mom. That's why you need moms, to watch you like a hawk. All right, Krista, Sitten. I'm having parathyroid surgery in September, and I would like to know how long I may have had this, and what complexity, if any, a previous thyroidectomy from 25 years ago and a vertebral artery dissection 5 years ago could bring. Well, you're not making it easy. Overactive parathyroid is 12 by 6 by 7 nodules centered near level of sternal notch. Just one causing problems. Calcium has hovered. Okay, so you're saying on your scans the parathyroid was found to be so the sternal notch, let's put it here. This is the sternal notch, and the clavicles are there. The notch is right there, and this is the sternum. So this whole thing is the sternum. The parathyroid is, I'll draw it in black, close to the sternal notch. Great. Okay. That doesn't tell me how deep it is, right? If it's superficial or deep, when you look at the cross section. Okay, but let me keep going. Calcium has hovered between 10.5 and 11.3. PTH has been between 133 and 144. 24-hour urine calcium very high at 528. So surgery is definitely needed. I really hope you can help. I've done extensive research, including purchasing papers from Elsevier, but it seems likely my situation isn't common. To make things more fun, this is my first year with Kaiser, previously UCSF, and though my doctor seems well qualified, I'm still a bit nervous due to previous thyroid removal. Sorry, that was a mouthful. I will be watching and hope. Okay. All right, so the vertebral artery are the arteries. So the arteries that are next to your spine. So if you look at the cross section here, your spine is back here, and the vertebral arteries are on the two sides of your spine, right? So generally speaking, they probably did the surgery from the front here, and they had to dissect either from the side to get to it, or go through the middle and push the thyroid aside to get to it. Okay? Either way, the area in question has been operated on twice. And not only that, that was 5 years ago, and many years ago you removed your whole thyroid gland, so there is scarring all over the place, right? So this is what I'll tell you, okay? If on the scan, the tumor that's here at the sternal notch, right, which is lower parathyroid, away from the area where your thyroid was removed, right? Your thyroid is here, a little bit above sternal notch, and this is lower. So if it's away from that, there's less scarring they have to deal with, right? If on the report it says that with respect to the trachea, this is the trachea, the breathing tube, and this is on cross section. If it says that it is the parathyroid, this time I'll draw the parathyroid in blue. If the parathyroid is next to the trachea, superficial, then I wouldn't even worry about this surgery at all, right? Easy to remove, right? Obviously, they have to have PTH testing in the surgery to make sure the other glands are either working fine or even are alive, because you don't know how many of your parathyroid glands survived your thyroid surgery, right? So you have 4 parathyroids, right? In your case, one of them is lower, that now is abnormal, right? You don't know when they removed the thyroid gland, if in the process of removing it, if they damaged or removed any of these parathyroids, damaged the blood vessels feeding the parathyroids, right? Or actually removed these 3 parathyroids. You don't know that. So when you remove this, you have to check your PTH to make sure those are working. So that's the nuance. If your surgeon is not doing intraoperative rapid PTH testing, don't do this surgery with them, right? First and foremost, they have to do that. Second, you have to see what the location is. It's the location with respect to the breathing tube is relatively superficial, then very little danger with doing this surgery. But the more experienced your surgeon, the better, okay? I feel like I've had some patients in common with the doctors at Kaiser Oakland, and they've been good, right? I haven't had any experience in the past 5 to 7 years, but prior to that, I think there were a few patients that came to me after having been seen at Kaiser Oakland, and some chose to have the surgery with me, and some chose to stay and had good surgeries done there. So you may want to check those folks out and see what they're offering you, okay? And if you're still concerned, you can message me and I can look at your information in more detail, or look at your imaging and see, give you more exact thoughts. Yeah. Okay. Good luck, my dear. Angie Fry, this may be beyond our current practice focus, but I'm learning about hypophosphatemia due to necessary iron infusion prescribed for iron deficiency. Okay. So apparently iron infusions, particularly Injectifar, can cause symptoms from mild transient drops in phosphorus to life-threatening hypophosphatemia. Accompanying are erratic. So in the kidney, when the kidney filters out when the kidney is filtering calcium that comes into it and lets go of it, it exchanges it for phosphate. So calcium leaving the kidney means more phosphate getting back into the bloodstream, right? So if the iron infusions cause your phosphate to come low, your calcium will shoot up because your kidney is trying to get rid of the phosphate. So there's a co-transporter or inverse, right? So that's part of the problem. I was fortunate enough to have only sustained a transient drop in phosphorus thus far. I haven't monitored other parameters. If you're inclined, I'd love to hear explanation and thoughts on this one. I mean, it's happening because of the way the kidney functions. And so, over time, as you're doing the injections, you're going to have to get lots of calcium phosphate measures before and after each infusion to see how the infusion is affecting your numbers, right? So that sometimes you may actually have to supplement before you get the infusion, supplement with phosphates before the infusion to compensate for it, okay? Good luck. It's not an easy one. Emily, what if your labs are inconsistent, like sometimes high calcium, other times not? It's not one set of labs you need to look at. It's both the calcium and PTH, my dear, right? So in a person who has very typical hyperparathyroidism, or the textbook, not typical, textbook hyperparathyroidism, you have really, really high calciums and really, really high PTHs. It's very clear what's going on, right? Calcium is, if the upper limit of normal is 2.5, 2.2. I'm mixing the European numbers with the US numbers. If your upper limit of normal is 10.2 in the US, right, and 2.6, let's say in the UK, in the European system, right? But now your calcium in the US is 11.5, in the UK is 2.75, right? And your PTH is in the US 200, in the UK system 10, or the European system 10, then you have clear numbers that are elevated, no doubt, right? But if you have one of these scenarios where you have normal calciumic, where your calciums are normal, right? Your PTH is high, the only way to figure this out is to keep looking at your labs over and over again, on multiple dates, fasting and at 8 o'clock in the morning, to see is this inconsistency between calcium and PTH persistent, right? Do I always have normal or high normal calciums and my PTH is elevated regardless? In which case I have to do further workups. In this scenario, I have to look at other causes of high PTH levels, right? If the scenario is such that I have erratic calciums that are sometimes elevated and sometimes normal. So sometimes this one could be 9, let's say 9.9 in the normal range, right? It's the PTHs that tell me if there's something going on there, right? And if the PTH, instead of these particular numbers, right? So if you have a 9.9 here and your PTH is 48, when your calcium is 10.6, your PTH is 25. And when it's 10.7, it's 20. Then those are appropriate numbers, right? On the other hand, having having these numbers makes this be inappropriate, even though this one set was normal, right? I would continue to get a few more sets, right? And if this inconsistency is present majority of times, then you have hyperparathyroidism and you have to deal with it, right? You also rule out all the other causes of high calcium in this scenario, right? But it takes a lot of effort, and you need to have a doctor that's vested in helping you, right? And understands. You have to sit down. I would, again, do those worksheets that I have for hyperparathyroidism. Put your symptoms, put your numbers, look at all the possibilities. Okay. Schiller Berwari, 40-year-old female, 23 years, dealing with kidney stones, joint pain for almost 10 years, bone density shows osteopenia at 40, very early for that. Elevated PTH, normal calcium levels, vitamin D 9 to 29 in 3 months, taking vitamin D 1,000 daily, normal nuclear scan, normal ultrasound. Options are surgery to remove 3.5 glands of or medication. Okay, so elevated PTH. If your elevation in PTH is not dramatic, right? So the range of normal PTH is 15 to 65. So if your PTH elevation is 75, that tells me that if this is a normal parathyroid size, right, that your parathyroid tumor is not very big, right? Which may mean that on an ultrasound may not be visible, right? And on a nuclear scan, very unlikely to show up at a PTH of 75, unless they're doing it really well and they scan you within 5 minutes of injecting you, and they're looking, that has a shot of showing it. But if they're not doing it really well, if they inject you and test you 20 minutes later, it'll never show up on a sesame B or a nuclear scan, right? I would suggest that you do a 4D parathyroid CT scan before deciding on what type of surgery to have, or if you have a PET choline available, then do that. If those are not positive, then you need to have a bilateral exploration, because your surgeon doesn't know which parathyroid may be abnormal, right? And it's still not a commitment to 3.5 gland removal. It is a commitment to finding all 4 parathyroids and seeing, based on what they see, if they think you have 1 adenoma, 2 adenoma, or you may have hyperplasia. In the case of hyperplasia, remove 3 gland to 3.5, and that's based on the size of the last gland and the experience of your surgeon. I would definitely do it with someone who does PTH testing during surgery. All right, find the most experienced surgeon. Do the 4D parathyroid CT scan if you can, or a PET choline if you can, and find an expert surgeon that does use intraoperative PTH testing. Good luck. Prerna Mansu. How many of the 4 glands do you typically remove? Will one of the 4 glands be implanted in the forearm? No. In a hyperplasia scenario, when I know that someone has hyperplasia, right? So let me show you. Okay, so this is when there's adenoma, this is when all 4 are abnormal. In a hyperplasia scenario, right, what I'm aiming for to do is to find all 4 glands, decide which one is the smallest, which is this one, remove the other 3 largest parathyroids, right? Check the PTH before doing any of that, which is 84 in this scenario, right? Once I've biopsied this thing, and I biopsy this usually first, the smallest one, I biopsy it to confirm that it's a parathyroid. Biopsy it first, remove these 3, okay, with its blood vessels in place, the blood vessel going in and the blood vessel coming out, right? So just to show again, blood vessel going in, it's always from the same side. The blood vessel coming out is also with it on the same side, right? So once I check the PTH, it's 84. I take these three out, and I have biopsied this one, just a tiny fragment, maybe 5%, right? And I check the PTH. If the PTH drops at 5 minutes, it's 30. At 10 minutes, it's 25, and 15 minutes, 17, right? Then I know the PTH came down, plateaued in the normal range, and it tells me that what parathyroid is left behind is functioning adequately. And I've left enough. I don't need to remove any more. I don't need to take it out and reimplant it in the arm, right? Because reimplanting it, if I were to take this parathyroid out, right, and cut it into multiple pieces and implant it in the muscle of your neck or your arm, there's an 80% chance that it'll work and 20% chance that that will fail, which will mean you'll be permanently hypoparathyroid. I don't like the possibility of 20% failure. That's way too much. So that's why I don't do reimplantation. And then Prerna asked, what's the effect of surgery on the vocal cords? I mean, on the vocal cords themselves, nothing on the, directly, but indirectly, the vocal cord nerves, which is, let's see, this is the branch of the vagus nerve that goes here and comes up. This is the vocal cord nerve here, and on the left side, the vocal cord nerves are relatively easy to find, right? And so if you have an expert surgeon, they should be able to find this nerve and protect it. If you've had previous surgery, it may be more difficult in your neck, but if you haven't had any surgery on your neck, then these nerves are usually very visible and easy to find, okay? So the risk of injury to them should be exceedingly low, significantly less than 1%. What are the side effects of surgery? Well, if you had one gland that's abnormal and you take that out, there should be no side effect to the surgery. So the possibilities are vocal cord nerve injury, bleeding from the blood vessel, or having more than one gland that's abnormal, right? Having all four, which it's not a side effect, it means a more complex surgery. You may have hungry bone syndrome if you have bad osteoporosis or bone loss, in which case your bones will try to grab the calcium, so you need supplementations after surgery, and so on. All right, good questions. Going on. Can long-term damage be done to bones, kidneys, brain, and heart following misdiagnosis of primary hyperparathyroidism? Well, yeah. I mean, you will continue to have bone loss, right? And it's very unpredictable to know if someone will get into osteoporosis or not, but the chance is there. Generally speaking, at least 2/3 of the people who don't treat their hyperparathyroidism will have progression into osteoporosis. Okay? Kidney, well, the more calcium your kidney has to filter, the more it works, the harder it's working, and the higher the possibility of it not functioning properly. Kidney stones are not a certainty, right, in all patients who have hyperparathyroidism, but once you get it, it's more likely to get more of them. High PTH levels cause the heart muscles to thicken. Calcium issues cause rhythm abnormality in the heart. The brain, the PTH can act like a neurotransmitter and affect many different areas of the brain, which can cause a lot of the brain symptoms. So at the time I was diagnosed, 2023, my calcium was 13.4 and PTH of 259. Holy moly. A 3.5 gram mass was removed. Lab work showed calcium levels 10.4 back to 2018 and kidney stones as far back as 2008. Okay, so your calcium was high in 2018. Okay, how concerned should I be regarding my bone, cardiac, and renal health? It seems that there is a little concern or follow-up once surgery has been completed. Well, what I would suggest that a year and a half after you do your parathyroid surgery, check your bone density, right? Because it should show improvement. You should continue to check your calcium, P2, and vitamin D yearly with your annual exam to make sure that you don't have another one that's abnormal and malfunctioning. This year, next year, or 20 years from now, it could happen. So you should check that. In terms of all the damage to other organs, all you can do is depend on your body's ability to heal, right? So by that I mean you should exercise and do weight-bearing exercises to improve your heart and improve your bone density. You should do memory games and challenge your brain and do all sorts of challenges, mental challenges, so that cognitive mental challenges, so that you improve that. You'll allow your body to heal and get better. And so, you should be concerned, but know that you can make things better, right? And I would check your heart. I would check your kidneys to see if there are any more stones that need to be addressed. I would definitely check your bones, right? All right, Nancy Lindsay. I have questions concerning the apparent disconnect between many endocrinologists and our endocrine surgeons. The endocrinologists tend to look only for frankly high lab numbers, worsening osteoporosis, fractures, and recurring kidney stones. Our surgeons take more nuanced views of the numbers and also seem to take into account our many other symptoms while still being cautious about promising relief following successful parathyroid surgery. Many of us have been chasing causes and relief from many ailments for years, working with our primary care practitioners, GI doctors, psychiatrists, nephrologists, sleep clinicians, endocrinologists, and perhaps others. Finally, we may find ourselves with a surgical specialist who this cuts off. But then, however, I feel the question should also be asked, could this be the case of Hammer, the endocrinology surgeon, seeing everything as a nail, misbehaving glands that need to be... Oh, very good point. All right, so how do you address this without offending anybody? Let's give it a try. So, I started my career as a head and neck cancer surgeon, right? And then focused my practice to parathyroids, and salivary gland tumors, right? And the reason for it is that there's many reasons. I had a family and children, so doing big cancer cases was not feasible with having a family and being involved with the kids. One main reason, probably the main reason, but the other reason was that I felt that we were doing too many thyroid surgeries. The endocrinologists were controlling the funnel of patients who had thyroid nodules, had suspicious thyroid nodules, had thyroid cancers, and were dictating what surgery they thought should be done. And I felt endocrinologists were over-aggressive in treatment of thyroid diseases, right, in terms of surgery, surgical options, right? And I didn't want to do as many surgeries, thyroid surgeries, and I didn't think it was right to do as many thyroid surgeries as dictated, and I didn't feel that the extent of the surgery being done was appropriate. I thought we needed to have less surgeries, half of the thyroid removed or a portion of the thyroid removed, rather than the entire thyroid being removed. And so me and the endocrinologist couldn't see eye to eye on that 15, 20 years ago, right? And that disconnected us to some extent because they didn't like the way I was practicing, I didn't like the way they were practicing, right? Fortunately, over the years, the more data came in and was understood by the general endocrinology community, it became very clear that we don't need to be as aggressive with thyroid. And thyroid cancers, we have to be appropriately aggressive, right? But at the same time, as I thought the endocrinologists were overly aggressive on thyroid disease, I felt like they're under-aggressive with parathyroid disease. And the reason is that thyroid is very different. When you have thyroid cancer, let's say, or a thyroid tumor, and I remove half of your thyroid, you may have deficiency on thyroid hormone, in which case you go back to the endocrinologist, and for the rest of your life, the endocrinologist helps you control the level of thyroid hormones. They're involved with your care. They see how this disease affected you, how the surgery affected you, what are the long-term consequences, and how they can help. When you have hyperparathyroidism, right, and you remove this abnormal tumor, right, once this is out, the remaining 3 parathyroid glands take over the job and produce hormone, and you don't need to ever see an endocrinologist. So an endocrinologist is not going to see you with your symptoms that you're having right at this moment, how you are a year from now, how your life is dramatically better, right? What do they see? Because you don't need to see any doctor. The abnormal tumor's out, the hormones are working, you're fine, you have your life back, you don't need a doctor, you're out of that game, right? Nobody gets to see you, right? A lot of the surgeons don't get to see you because they're not following their patients. I follow my patients. I'm annoying that way, but I send surveys even 4 years down the line trying to get to see how my patients are feeling and doing, right? But we, as surgeons, do get to see a lot of our patients. When we do the surgery, they'll come back and say, in the recovery room, oh my God, my bone pain is gone. 1 week later, when they come to have the wound check, for example, oh my God, I feel so much better. I feel like a weight is lifted off my shoulder. I see the world. I think clearly. We get letters all the time. I get letters from my patients who've done I've done surgery on 10 years ago, sending me letters to thank me and saying, oh my God, I feel younger today than I did before surgery, right? So we get directly or indirectly follow-up from our patients because the impact of this surgery is so massive in so many of the patients' lives. Does that mean everybody gets dramatically better? No. I think the longer you've had this disease and the wider the gap between your natural calcium and the diseased calcium, the less improvements you're going to get, right? So the higher the difference between the two and the longer you're in that state, the more permanent are some of the things that have been done, like high blood pressure. Because at that point, the high blood pressure is caused by calcifications in your blood vessels, and your blood vessels are not as elastic. That's not going to change back, right? If your heart muscle has thickened, it's not going to thin out anymore. It's just going to be thicker, you know? So some of these things are permanent. If your kidney fails because you produce too many kidney stones, then it's failed and gone, right? So some of the effects are permanent, and some of them are reversible, you know? And so the sooner you address it, the better, right? Especially if you're having symptoms or bone loss or any kidney malfunction, right? If you have symptoms that are affecting the quality of your life, I think they should be addressed, right? So now, in terms of the surgeons being a hammer, all of medicine is unfortunately like that. There are studies that show that when doctors go to conferences and there are lectures about rare diseases, they come back and they identify those rare diseases more often, right? Because they're looking for it. They're in front of their head. So if you have someone who is treating hyperparathyroidism, is it more likely for them to diagnose hyperparathyroid? Yes. Is it more likely for them to say, you have symptoms, I feel like these symptoms are probably affecting the quality of your life, right? And you should have treatment, probably, right? Because they've seen it more. Hyperparathyroidism is odd because some people, most people, you're helping by taking out the diseased parathyroid and putting them on the path of improvement. Some people who've had this disease for a long time, all you're doing is stopping the progression of this disease. So they may not get it dramatically better, but you stop them from getting worse. So you stop their heart from getting thicker, heart muscle from getting thicker and more heart disease. You stop the progression of their mental malfunction, at the speed with which it's degrading and their fogginess is proceeding and memory loss is proceeding, right? You slow that down. You slow down the damage to the kidneys, and so on. So I don't know how to answer you any better than that, except that yes, the parathyroid surgeons tend to treat more patients than the endocrinologist would, right? And I find endocrinologists to be supremely conservative. And again, the endocrinologists don't get to see you a year down the line, 2 years down the line, or 5 years down the line to see how much better. They only get to see the people who've had failures of surgery, and then they go back to an endocrinologist to get diagnosed. They see, oh, this is failed surgery, you have hyperparathyroidism still or recurrence, and you need to have surgery again. So their view is a little bit skewed against surgery, I would say. Okay? So very good question. I think a terrible, long-winded answer, but there it is. Okay. So 32-year-old female on July 2nd, 2025, PTH is 147, calcium is 10.5. Okay, so clearly high numbers. Vitamin D 28, 24-hour urine calcium is 280. Okay, so vitamin D is slightly low, but that wouldn't explain why calcium would be high. Calcium should be low if your vitamin D is low, because vitamin D helps you absorb calcium from your food, right? Okay. Thyroid ultrasound showed solid or almost completely solid hypoechoic nodule on the right isthmus, wider than tall in shape, 0 points, lymph nodes, no significant abnormality, nuclear med, parathyroid SPECT, and CT result in no findings, suggests a parathyroid adenoma, low energy, hair loss, muscle spasm, calves, and frequent thirst and headaches, no history of kidney stones, no FHH, genetic disorders, sometimes feel bloated and constipated, feels like trapped gas in stomach, had endoscopy with pathology samples normal. What could be the cause? Well, you have hyperparathyroidism. That's the cause. And you should take vitamin D, but that's not going to correct the problem. I would suggest that you do a 4D parathyroid CT scan. Again, sesame B scans are not reliable, right? As you can see in your scenario. Ultrasound won't show a parathyroid that's deeper, okay? Because when you look at ultrasounds, you can see here, beyond this point, the ultrasound is not really showing anything. So there's only a certain depth that your ultrasound can show, right? So if this particular parathyroid, instead of being here, was here, when the ultrasound wouldn't pick it up. Okay, so I would suggest that you do the 4D parathyroid CT scan or a PET choline scan, right? 4D parathyroid CT scan is much more available, and that will find. So let me show you. This parathyroid is behind the sternum. This is the sternum bone, right? The chest bone. This parathyroid is here, behind the chest bone. Ultrasound would never see it, right? And the sesame B clearly is not picking it up, right? Or this parathyroid, which is behind the thyroid gland and close right by your spine. This here is the spine. at the front of the spine. This is the esophagus, the swallowing tube. Let me draw it in red, right? Ultrasound probably would reach to this level and not show it, right? So I would do a 4D parathyroid CT scan. All right, we are done with the questions that came in beforehand. Let me go through the list and find the questions that have come in as we've spoken. Mino, my mother is 70. She diagnosed with having 4-gland parathyroid hyperplasia. She has nodules as well as she has nodules as well, but FNA said that they are okay. So the thyroid nodules were benign. Her PTH is on 138 in one examination, then later 183. Okay. She had moderate level of osteoporosis. Doctors here say that she's not a surgery candidate. One doctor prescribed cinacalcet. The other saying taking alendronate sodium, an active form of vitamin D, 5 times a week. I don't know what to do. 70 is not old. So for your doctors to say that she's not a candidate for surgery, she must have some other condition that precludes surgery. So she must have terrible heart disease, lung disease, kidney disease, something to that effect. Otherwise, I operate on 70-year-olds all the time who have hyperparathyroidism, and they do amazingly well, even if they have hyperplasia, right? So if these other conditions prevent your mom from having surgery, then I would say the combination of cinacalcet and alendronate is appropriate, right? Cinacalcet is designed for people who can't have surgery or have kidney failure or have parathyroid cancer. So your mom, if she's not a surgical candidate, it would apply. But find out why she's not a surgical candidate. If they say because the surgery is too hard, but she's a healthy 70-year-old, then that's not an answer. That's definitely not an answer. Okay? Willow. I had hyperplasia 2 years ago. I just had my labs done. PTH is 26, vitamin D is 53, calcium 10.6. Is that calcium too high? I do take that. Yes. I would check your calcium. Willow. Here, Willow has another. Calcium is 10.2. Okay. Willow, I would check your calciums 2 more times, fasting and at 8 o'clock in the morning. If both of those times you find similar numbers where you have elevated calcium and PTH numbers are low, and this is when you've taken yourself off the calcium supplements, right? So 2 weeks after you take yourself off calcium supplements, I would do the blood test twice in a row, 1 week apart, right? And if you find that your calcium has not normalized and is still elevated, then you're going to have your doctors do a workup to see if you have any of the other causes of hypercalcemia. And I would take a picture of this and take it to your primary doctor or endocrinologist. Say, can you work me up? I have high calcium numbers. I'm concerned. I want to make sure. And if the workup doesn't show that you have any of these conditions, right? Well, any of these conditions, then what you may have now is normal calcemic hyperparathyroidism, okay? But you'll need an extensive workup, okay? Good luck. You need a good doctor that's interested. Chrissa Sitton. Hi there. I'm hoping you can address having parathyroidectomy after having a thyroidectomy 25 years ago. I know it is treated as a resurgery, but I'm wondering what the actual complication difference is. I have a surgeon that does 50 to 100 surgeries in a year and teaches the residents. Has done surgery for 20 years. Does any of that? Does only the complicated surgery? Is that enough to say he's high volume? It sounds like he's high volume, Krissa. That sounds really good. You need someone who does 50. Yeah, 50 is the minimum number. Okay. The complexity in that is that when you have thyroidectomy, and I think we addressed this before already today, but let's look at it again. When you have a thyroidectomy, right, where your thyroid, your entire thyroid is removed, then what you have left in its place is some scar formation in these areas, right? And let's zoom in. So if you have scarring here where you had surgery before, that means you have scarring in the area of the voice box nerve and in the area where your parathyroids, let me draw the parathyroids in blue, where your parathyroids normally exist. And then that make it harder. Do we do surgeries, reoperations? All the time. Have I done surgeries on someone who's had previous thyroidectomy? All the time. It happens, unfortunately. Is the risk higher? There's two risks that are higher. The risk of injury to the vocal cord nerve. So I always use a breathing tube, right, that goes in the here, that has vocal cord nerve sensors on it, right? So they sense activity in the vocal cord. So every time I get close to the nerve, it gives me a warning, right? That improves the safety. I do PTH testing. I may even bring an ultrasound machine and during the surgery and look inside the wound to see if I can find the parathyroid scar formations and so on. So the risks that are higher are the risk to the vocal cord nerve, which goes from 1% to about 5%, and the risk of not finding the parathyroid because of scars formation. Those are the main risks, I would say. The other risk is that the parathyroid that's abnormal here may be the only surviving parathyroid after a thyroid surgery, because all you need is one parathyroid to be fine for you to be fine. So if these other threes were knocked off during your surgery or removed, and the one that was left behind got a tumor in it, now you're out of luck. And that's why PTH testing during this surgery is crucial, because if you take this out and your PTH goes from 100 to 0, then you know that you have no other parathyroids, and a portion of this parathyroid needs to be cut into pieces and placed in the muscle of your neck or your arm. Okay? Very good question. Best of luck, my dear. It sounds like you may be in the right. Minu asks, my mother consumes haloperidol for the last 2 years. Can it be the reason for a PTH going up? No, haloperidol has no connection. But haloperidol is used for mental changes and anxieties that go along with it, and so on. And it's not a great medicine for long-term use. And hyperparathyroidism could give her symptoms that mimic psychosis, mimic mental status changes, which would cause people to put her on haloperidol. So again, just see if your mom is a candidate for surgery in terms of her physical ability to have surgery. Because if she does, then definitely proceed. Rachel Kinney, why is there such a wide range of difference in PTH lab ranges? Our local clinic's PTH range is 15 to 95. My PTH was 60, 80, and 95. And 102 was the highest. My primary hyperparathyroidism got missed in labs for over 15 years. Ultimately, I was one to figure it out. My calcium ranged from 9.5 to 11.4. I had 2 centimeter adenoma. Often my lab showed normal hormonal hyperparathyroidism, sometimes normal calcemic hyperparathyroidism. Very good question. The reason is that what we see as the range of normal in the laboratory is so this is how laboratories come up with the ranges of normal. So Quest Labs, let's say, in Southern California, will look at 5,000 healthy adults that are not taking any medications, have no disease, and look at their PTH levels, right? And everything in the biological systems follows a bell curve, right? It'll be like this, right? So these are normal healthy people, have no hyperparathyroidism, right? And they'll say, okay, well, look at these numbers. We're going to look at the mean, right? And go 2 standard deviations, right? And set the normals to be 2 standard deviations above and 2 standard deviations below the mean. And we're going to say this is our normal. So in the labs that I use, this is 15 to 65. 5 miles over from me, a hospital has the same lower limit, but the upper limit is 80, right? And it's all because of that particular 5,000 that they took, and the statistical analysis that they did gave them this range. So your lab uses 15 to 95 based on this evaluation, not based on the fact that at 66 people have symptoms because physiologically it's abnormal, but because statistically it's outside the 2 standard deviations that the lab chose to use for normal, right? So the normal reference ranges are not normal based on function, they're normal based on statistical values. And so that's why you can't look at absolute numbers and the normal range that the lab gives you. You have to look at the relationship between calcium and PTH to figure that out, which fortunately, Rachel, you did yourself. Terry Hinnenkamp, I bet hypocalcemia when I take vitamin D that is 125 and get kidney stones. I get hypocalcemia when I take vitamin D and get kidney stones. I have cystic kidneys and medullary kidney disease, so I am told not to take vitamin D. Well, I mean, the way your kidneys functioning is not normal. So if your reaction to taking vitamin D is to make more stones because the vitamin D is preventing you from releasing calcium in your urine and holding on to it, then that's what you got to do. But you got to talk to a kidney person, not me. Pamela Jane, although hyperparathyroidism is uncommon in children, I'm curious about the effect on the body if they're in their growing years. Very, very deep effect. I had a young boy who was, I think at the time, 11, come to me from the UK. They weren't offering him surgery. He had low energy. He was just not. He was trying to be athletic and in sports and wasn't working out. He had a very short stature. He did surgery, and 9 months later, her mom sent me pictures of him skateboarding around town and being all happy and jolly. And then 3 years later, she sent me pictures of him now being over 6 feet tall, and being very tall essentially. So it has deep impacts on young kids. So definitely do the surgery. The impact can be big, and you'll see it, and your son will see it too. The quality of his life will dramatically improve. Okay, Leslie Ahern, how long does a person's vitamin D level have to be normal before ruling out secondary hyperparathyroidism due to vitamin D deficiency? I would say within a month or two, if you normalize your vitamin D, your calcium and PTH numbers should normalize. If after 2 months your vitamin D is normal for 2 months and your calcium and PTH are either one of them are staying high, you need further investigation. Is a single test result with normal vitamin D, high calcium, and high normal PTH enough? No. I would do a minimum of 2 fasting at 8 o'clock in the morning, if not 3. If a person is normal hormonal, do they usually remain normal hormonal, or do their PTH levels tend to increase through the years? So people are normal hormonal because they have PTH receptors that are, PTH receptors that are less sensitive, right? So people who are hyper hormonal, having hyperparathyroidism, meaning high calciums, generally when you do surgery, their PTH levels normalize into a higher average, right? People who have slight elevations, or mid-range, people who are normal hormonal, when you do the surgery, their average PTH afterwards is in the low normal range. So it is thought that they have very sensitive PTH receptors, just like many people are sensitive to medications. Some people will take one ibuprofen and it takes away pain, and it may give them other symptoms and headaches and nausea, right? And others will take 4 of them for the same type of pain and not have improvement of their pain, you know? So we're all different in our sensitivities, and that has to do with the affinity of receptors for these drugs and affinity of receptors for PTH. So the higher the affinity, the higher the stickiness of the receptor to PTH, meaning it attracts the PTH more and sticks to it more, the less PTH you need to have an effect. So in a normal hormonal person, you don't need as much PTH. And is it possible that in time the parathyroid tumor, right? So if this is your thyroid, and you have 4 parathyroids in it, and this is the abnormal one, and it doesn't need to be big because it doesn't need to produce a lot of PTH to cause hyperparathyroidism. In time, this tumor will continue to grow and this PTH number will increase, but it may be decades, right? So you can't wait for that. You have to diagnose the hyperparathyroidism based on the relationship between calcium and PTH. Does having kidney stones correlate with a higher chance of having one adenoma? No. Unfortunately not. I had kidney stones during the perimenopause and a few years after pregnancy. Could there be a relationship? Well, yes. I mean, if you have hyperparathyroidism, which is more common in middle-aged women in times when menopause is occurring, and then all of a sudden you start having kidney stones, then it's more likely that you have hyperparathyroidism, not necessarily that you have parathyroid adenoma. Could there be a relationship between hyperparathyroidism and certain hormones? There are some studies that show that there is some relationship between estrogen and PTH, not causality, not causing hyperparathyroidism, affecting the number a little bit. What is the effect of hormone replacement on PTH and calcium levels? Very little. You know, with hormone replacement, you get more mineralization of your bones, so more calcium leaves your blood to go into your bones, and you can have a PTH elevation, right? Because there's less calcium available in the blood. But if you give yourself enough calcium supplementation, that should normalize everything. Candace Woodruff Russell. My doctor thinks I've had this since 2016. My calcium has been high for that long, and every doctor told me I was fine. Now the scan shows my spine is into the osteoporosis range, negative 3.5. How long should I wait after surgery to start medicine for my osteoporosis? Candace, I would suggest that you do a bone density at 1.5 years after your surgery. And during that 1.5 years, do weight-bearing exercises. Go hiking, walking, carry weights with you when you hike, or walk around town, or run. Put pressure, do weight-bearing exercises, lift weights, right? Those force your bones to get stronger. So at 1.5 years, if you do a bone density and you see your bone density is already improved, you don't need to take osteoporosis medication. You can you know that you've improved your bones by yourself because you have healing abilities. Studies show that all people who've had successful parathyroid surgery have improvement in their bones, right? So you can improve your bones without needing medications. H, I have primary hyperparathyroidism. I have upcoming surgery to remove one of the gland that is malfunctioning. I have osteopenia, fatigue, sluggish memory, and feeling so tired. Hope surgery will help to reverse symptoms. I also have dry mouth, maybe unrelated. It's very possible that your symptoms will improve. For sure, your bone density will improve. Okay, but you need to be very active in taking care of it. Ben Carson. Hi, Dr. Larian. I now have contact with a new endocrinologist. He's trying to talk me into not seeking a third operation because of the risk due to the scar tissue. She's got me to try Sensipar, but I have chronic stomach issues and cannot handle even worsening stomach issues due to Sensipar. I do not know what to do. I'm pushing 76. And do you have any advice what I can do to feel less worried? I mean, right, you got to treat the hyperparathyroidism. I mean, the two options are either surgery or medications. And if you can't tolerate the medication, I think the only choice you have is surgery. You've sent me your images. I think your parathyroid is accessible, right? I don't know what to tell you, my friend. I can read your surgery report, but I know the surgery reports from the Nordic countries don't have a lot of detail. The ones I've seen are very rudimentary and basic, but I can read your reports and give you a guesstimation as to whether the scarring is going to get in the way to do the surgery or not. I've done surgery on people who've had 3, 4, 5 previous surgeries. Okay, it's hard. It's not easy, but it can be done. Pam Kelly. I'm joining in late. In what situation might medications such as cinacalcet be used to control persistent hyperparathyroidism instead of a second surgery? Well, it is an option in everybody who's had previous surgery, right? So, generally for my patients, if they've had a previous surgery that was, let's say, successful and 10 years later they get another parathyroid, or they've had a previous surgery that was unsuccessful, right? And now they need a second surgery. Majority of times I'm able to do the second surgery for them, right? I'll do scans and try to identify where the parathyroid is. But a second surgery is very possible. Now, if the person has other medical issues that make a second surgery not suitable at this point in time, then I would give them cinacalcet or Sensipar. Same medication, different names for the same medication. If they have now kidney failure and they're having a hard time, or they have heart disease, lung disease that prevents them from having surgery, definitely Sensipar. If they had a vocal cord nerve injury during their first surgery, and now the parathyroid that is abnormal is on the opposite side where they have a healthy nerve and they don't want to risk that second nerve, I certainly would understand that. I would in fact encourage them. If the parathyroid is close to the area of the nerve, I would encourage this person not to have surgery and take cinacalcet instead. So there's many good reasons to take cinacalcet. And majority of patients are not like the last person we talked about, Ben Carlson, who unfortunately has having a lot of GI upset from cinacalcet. 95% of patients that I've placed on cinacalcet don't have any problems at all, right? And so it's a pretty good medication as an alternative, right? But it doesn't cure you, right? You have to take it for the rest of your life, right? So, and if that works for you, then that works. There's no questioning it. And if you take cinacalcet for 5 years and you decide you don't want to take it anymore, you want to have surgery, you can do that too, okay? The only issue with cinacalcet is that there's no study showing that taking cinacalcet allows you to have improvement in your bone density, right? And then you're forced to take an osteoporosis medication along with it, right? And so now you're taking more and more medications for the rest of your life. right? And that should be in the consideration for your choice, okay? But ultimately, it is your choice. Wendy Frederick, hyperplasia, 3.5 glands removed. Do I need to continue to take supplement calcium? 1 year post surgery. It all depends on your labs, dear. So if you're 1 year post surgery, your calcium is normal, your PTH levels are in the normal range, and you have a lot of calcium containing foods in your diet, lots of green leafy vegetables, almond milk, dairies, you're French, and you have your cheese 3 meals a day, or Iranians, we have a lot of feta cheese in our diet, or Greek, or whatever, right? Then you may not need to take it. If, on the other hand, you're a year out, your calcium is normal with your supplementation, but your PTH is exceedingly low, and you also need to take activated vitamin D to support yourself, then your half a gland is not producing PTH. You need to figure out if that half a gland is producing adequate amounts of PTH. And the only way to do it is by doing labs now while you're on the supplements, right? If the labs look good, then you decrease your supplement and you check labs 2 weeks later, right? And see what the numbers look like. If the numbers look good, you decrease your calcium even more, or you stop it and you check your labs again. Okay, so Wendy, yeah, that's the path to seeing if you can get off of it. Anastasios Dembegiotis. I know I massacred your name, and I apologize. So June 3rd, removed 2.5 glands that 2 bottom showed on scans as slightly elevated. My blood tests all normal except slightly elevated PTH. But over a decade, I have osteopenia, now osteoporosis. I'm 62.5. Pathology showed nothing on the removed glands, and my last blood test went back to 81 hours after the PTH dropped to 50. And I am prescribed bone-enhancing med, no kidney, no other issues, and I'm very, very fit. What do you recommend as next step? I recommend that you wait at least 6 months after your surgery and check your labs again, right? If at 6 months your PTH is still high, if your calcium is even high normal, right, and your PTH is elevated, and your vitamin D is normal, and your PTH is elevated, then you have persistent hyperparathyroidism, and you should do scans again. Hold on. To see if you can find that 4th gland that I'm assuming they didn't see because they removed 2.5 glands, right? If they removed 2.5 glands, they must have not seen the 4th gland, right? And assume that you may have only 3 parathyroid glands. 3% of people have only 3 parathyroid glands and not 4, right? And in the scenario that you have hyperplasia in all of those 3 glands, then you remove 2 and half, right? So you remove 2.5 glands. So if they did that for you, that's what I'm assuming. So again, if at 6 months to a year, your PTH numbers are still elevated, right? Then you have persistent hyperparathyroidism. You should do a 4D parathyroid CT. Start with an ultrasound, 4D parathyroid CT scan or a PET choline scan, and see if you can identify where the 4th gland is. Okay, and then address it. Okay, Joe Carroll Siborovsky. Hello, Joe Carroll. My dear Fonzie, it's good to hear from you again. Do you have any advice for those seeking a diagnosis in regards to a first appointment with a new doctor? Should a patient refrain listing every symptom risking dismissal? No, I think you should take the worksheet that you have. If you're going to see, especially if you're going to see a primary doctor, take the worksheet, right? Because most primary doctors are not as informed as they should be about hyperparathyroidism. Go to the website, parathyroid.net, print this worksheet up. It has 2 pages. Fill it up, right? Take it to your doctor's office and say, I have majority of the symptoms here, right? I need labs. I need a workup. Please help me out. I think I may have hyperparathyroidism. Let's do labs and make sure you do the labs fasting at 8 o'clock in the morning because PTH numbers vary during the course of the day, and you have some surges that are physiologic. You don't want to get a lab at a time where you have a surge and get misdiagnosed as having hyperparathyroidism when you don't. Okay, so please do that. Good question, Joe Carroll. Jasper Hayes. Let me add to this, to what Joe Carroll says. Parathyroid patients generally, by the time they come to their doctors, have a lot of anxiety, right? They have mental fogginess, they have memory issues, they keep repeating themselves. They can sound, for lack of a better word, insane, okay? They can sound like they're crazy, right? And it's easy to dismiss them. So print down the sheet, organize your lab, organize every bit of information you have. If you have labs from before, take it with you. If you have had multiple calcium tests over the years and you found that your calcium numbers have risen, take those numbers and labs and they organize it in a table and give it to your doctor. Make sure when you're in there, you're not repeating yourself. Make sure you're not, I'm asking you a hard thing to do because it's not in your control to some extent. This disease is making you do this. But make sure you go with a family member that is your advocate, right? That says, hey, my friend, my sister, my brother was this vivacious, bright, intelligent human being, and as of 3 years ago, all of a sudden he rapidly changed, right? And I see it in front of my eyes, right? Take that person with you so that when your mental fogginess, right, makes you keep repeating yourself or be erratic in terms of your thing because you're ill and you're suffering, right? And you're doing your best, right? Your friend, your partner, your family member, your kin can help bring you back and navigate you through this thing, and let the doctor know, no, there is something wrong. You know, this is not a neurotic person just spewing out something else. This is not an anxious person coming up with an illness. This is a truly affected human being that needs absolute help, right? So either you organize yourself or have someone who loves you help you organize everything, right? I often find that because this disease is not diagnosed so much and people who are affected by it start behaving in strange ways, even their partners, their spouses get fed up with them, right? Which is terrible, right? Because right when you're sick, the person who's supposed to love you and take care of you is the one who can be most tired of this thing, but it's not your fault, right? And you may need to engage them into saying, hey, look, of all these symptoms listed on this sheet, right? I have all of these, right? I have joint pain, I have constipation, I have nausea, I have nighttime urination, I'm not sleeping well, I'm not feeling well, I have heart palpitations. Of all these things, look at this list. You know I have all of these symptoms, right? Help me organize myself to get a diagnosis because this is curable, right? I don't need to take anxiety medication. I'm not need to take antidepressants. I need to get rid of this. And then you can engage your loved ones to help you with this. That's what I would say. Get them to help you, okay? All right, Jasper Hayes. How long does a person's vitamin D level have to be normal before ruling out secondary hyperparathyroidism? I would say 2 months is enough, all right? Parathyroid hormone half-life is 5 minutes. It immediately reacts to the environment of calcium, right? So if you normalize your vitamin D, which means that you now are absorbing more calcium from your food, within a few weeks you should have the right answer, but if you wait 2 months, you will have a clear answer, okay? What is the effect of hormone replacement? Again, there is some connection there, but not deep. We just talked about it. AJ Dasuja. Sir, my 24-hour iron calcium is 228. Calcium is 11.6, PTH 94. 94 to 65. After 7 weeks of vitamin D, doctor is not sure. I'm sure you have hyperparathyroidism. Of high calcium, high PTH, right? There, you have hyperparathyroidism. That there's nothing else on. Okay, Anastasios responds that my PTH dropped to 43 after surgery. Yes, but what is it now? You have to wait 6 months afterwards to see if that PTH number stays or is it rising up, okay? So keep looking at the numbers before you make a decision. Linda Victoria, are anabolic steroids better for severe osteoporosis after surgery? No, weight-bearing exercises are the best thing for your bones. Steroids are not. Minu, can thyroid nodules which are near parathyroid affect them and cause them becoming bigger? No. No. Thyroid nodules don't affect parathyroids and parathyroids don't affect thyroid nodules. Scorpions and roses. I had an ultrasound and then SPECT CT and both resulted, no, I don't know, but in the ultrasound they found a nodule on the isthmus. Can this be causing high PTH and low vitamin D with high calcium? I mean, that nodule could be an intrathyroidal parathyroid. That's possible, right? Unfortunately, this just shows that doctors take you more seriously when you bring someone with you, preferably male. Do you agree? I don't think... I mean, I grew up in a family where my mom was, for a lack of a better word, badass. She was awesome and wonderful and as cool as can be. So men didn't seem more solid than women in my household, right? And so that doesn't make a difference to me, right? You just need someone who's sensible and reasonable, who cares for you in that room, who's gonna advocate for you and present your case, and also temporize things with the doctor and make sure the doctor doesn't dismiss you, right? And if your loved one comes in the room and says, you know what, this doctor is an idiot, right? They help you find someone else, okay? Right? You need that help with this environment. You know, is the unfortunate situation of this world that there are more male doctors, and I really feel in the next 50 years that's going to change, right? But it is, right? That's what the world is now. Are more male doctors likely to take male patients or people more seriously? I mean, I haven't seen it, you know, at this point in my life, in the modern times, in the area that I live, but I can see that being the case in the world, you know. So yeah, you may want to do that if you have that as an option. But if you don't, if you have the most sensible person in your family is a woman, that's the person you take, right? That's the one. Forget about the doctor's biases, right? Anyways, Minu, doctor, I guess that you Iranian, but in Iran, parathyroid surgery is so limited. They told me we just plan surgery if there's a no, we cannot do anything when all 4 glands. That's not true. That's not true at all. I mean, probably it's the dominant thing, but I know parathyroid surgeons even in Iran who do parathyroidectomy on hyperplasia patients. I mean, anyways, good luck, Mina. And that's it. I think that's the end of our questions. Thank you for all your wonderful questions. I really appreciate it. If you have more questions and concerns, please don't hesitate to contact me. There's good content on the website. I'm actually working on a new version of the website that has a lot more information. Hopefully that'll be coming out soon. Thank you for your attention and your questions. And hopefully this is helpful. and we'll be chatting again in a month. Have a wonderful day.